Mingalaba. It's an honor for me to welcome you today for the WHO Myanmar webinar to share the WHO recommendations on the intrapartum care for a positive childbirth experience and labor care guide to the all concerned stakeholders in Myanmar. On behalf of the WHO, let me cordially welcome you for this webinar. As you know, one of the core functions of the World Health Organization is the development and the regular updations of the global guidelines, ensuring the appropriate use. WHO technical guidelines based on evidence will help the end users to make informed decisions on whether, when, and how to undertake specific actions with the aim of achieving the best possible individual or collective health outcomes. WHO country officers are responsible for introducing such evidence-based guidelines and recommendations to the countries. To promote this important function, WHO Myanmar is organizing a series of online webinars this year to share the updated WHO recommendations and guidelines on reproductive, maternal, newborn, child, and adolescent health to all concerned stakeholders. We are inviting the policymakers, implementers, and managers of these RMNCAH programs, professional associations, NGOs, and other organizations, and all health professionals, including doctors, nurses, midwives, and so on, from both the public and private sectors to join these webinars. And we are happy to see you all connected together as one workforce. Being the first of these webinar series, we conducted a webinar on WHO recommendations on antenatal care for a positive pregnancy experience on the 3rd of February this year, in which more than 300 participants joined. Learning from this successful event, we are organizing today's webinar to share the WHO recommendations on intrapartum care for a positive childbirth experience and the labor care guide. I'm so confident that we all agree that all women should have access to skilled care during pregnancy and childbirth to ensure, prevent, and detect, and for management of its complications. To eliminate preventable maternal and newborn deaths, it is essential to receive assistance by properly trained health personnel working within an enabling environment. Thus, a key strategy to ensure skilled care during childbirth is that all births, at least all high-risk births, take place in health facilities, which we call institutional deliveries, where obstetric complications can be promptly treated as they arise. In 2018, WHO published a consolidated set of recommendations on intrapartum care for a positive childbirth experience. These guidelines specify evidence-based practices that should be implemented throughout labor and the immediate postnatal periods and discourage ineffective practices that should be avoided. To facilitate effective implementation of the above recommendations, WHO has reviewed and revised the previous paragraph and redesigned as the Labor Care Guide, we call it LCG, Labor Care Guide, for health personnel to monitor the well-being of women and babies during the labor. This tool aims to stimulate shared decision-making by healthcare providers and women, and to promote women-centered care. The main objective of today's webinar is to share these updated recommendations and the LCG tool with all our implementing partners. While appreciating your participation in today's event, I trust you will better understand the latest evidence-based WHO's technical recommendations on intrapartum care and how to use the WHO's labor care guide as the next generation partograph. Further, I would like to thank the resource persons from WHO headquarters in Geneva, Dr. Mercedes Bonet from the Department of Sexual and Reproductive Health and Research, and Dr. Justine from the Department of Maternal, Newborn, Child and Adolescent Health and Ageing for supporting us for this event. I also take this opportunity to thank Dr. Annoma Jayatilaka from WHO Southeast Asia Regional Office and Dr. Nilmini Hemachandra from WHO Country Office for their kind support in organizing this webinar. The RMNCH team members in our country office, Myanmar, they are the key players of this event, and their contribution in organizing this webinar is highly valued. Thank you all, and wishing you all the best for a successful and a productive event to be able to learn more on intrapartum care and provide better care for mothers and children in Myanmar. Thank you very much.
This time, we will focus on the recommendations on intrapartum care for a positive childbirth experience and the WHO Labor Care Guide, which is the tool that was adapted from the previous partograph to incorporate these new recommendations. And at the end of the month, during the next webinar, we will be talking about recommendations for a positive postnatal experience, and then giving you a summary of other implementation tools that we are developing. But today I will start with some background across both intrapartum and postnatal care, and some of what I call the unresolved issues and what is important for us to keep working on improving quality of intrapartum and postnatal care for all women and babies. This childbirth and the postnatal period is the periods where the highest maternal perinatal mortality and morbidity occurs. And in an effort to try to prevent or manage those complications, sometimes what happens is that a lot of interventions are done either to the woman in labor, during childbirth or afterwards, or to their babies. And this is what we call the over-medicalization of childbirth, which sometimes means that some ineffective or potentially harmful practices are implemented in hospitals or even sometimes by women themselves and the families. And we will be discussing some of them towards the end of this presentation. What we also know, and it's another issue, is that there's high levels of mistreatment of women across different settings and levels of healthcare in facilities, mainly, both to the women themselves, but also to the newborns. And you might be aware, we conducted a study a few years ago. Myanmar was one of the countries where we assessed mistreatment of women along other 3 African countries. And what we found is that around 1/3 of women included in that study felt that they were mistreated. This could be verbal, physical mistreatment, or some kind of discrimination toward herself or the baby. So still high rates of mistreatment that we will need to address. And finally, we move from this over-medicalization of childbirth to the postnatal period with somehow variations in lengths of hospital stay. Sometimes women and babies stay in hospital for very short periods of time that might not be sufficient for them to be well prepared to go back home and have a healthy postnatal period. And that's also an issue. This is accompanied by what we know is happening in many countries, very low postnatal care uptake, so women and babies not being seen by health professionals or skilled personnel once they are discharged from hospital. So these are the issues that we try to address with these two guidelines on intrapartum care and postnatal care for positive experiences. And as you can see here, this is a whole continuum. So the line doesn't stop, right? And even after the first weeks after birth, they will require health care. Hopefully for well women, well child care, but some of them we know will present some complications and will require additional care. That is not covered in the guidelines or not in these guidelines and won't be covered in the presentation that we will do today. And overall, the aim of the guidelines is to improve quality of what we call the essential intrapartum postnatal care. This is the care all women and babies should receive. And this is with the ultimate goal of improving maternal, fetal, and newborn outcomes. I'm sorry, I went too quickly there. The guidelines apply both to facility-based care, but also to care that may happen either at home or as outpatients when we will move to postnatal care in the next webinar. There's also something that makes these guidelines different, and is that through the process of developing the guideline, we prioritize women's voices. We did that through some systematic reviews. So we look at the literature on what women say about the care that they receive during childbirth and the postnatal period. And we incorporated that in the guidelines. So what is important to them, what matters to women in these periods, and also what are the factors that will influence their uptake of intrapartum and postnatal care. So to enter in the subject, the topic of the session today, the WHO recommendations on intrapartum care for positive childbirth experience were published in 2018. It has a large number of recommendations, so 56 in total, of which almost half are new recommendations. But there's a lot of these recommendations, 30, that were existing recommendations from other guidelines that we pulled together so you could have in one document all the recommendations consolidated, and then avoiding having to go to multiple documents to look at what are WHO recommendations for labor and childbirth. The guideline, as I mentioned it before, covers care for all healthy pregnant women and their babies during labor and childbirth in any care settings, but it won't cover management of complications in case they arise. We describe some guiding principles in the guideline on what we call the WHO intrapartum care model. That is the figure you can see on the right hand side of the slide. The woman and baby are always at the center of that care. And the care will include respectful care, emotional support, effective communication, pain relief, regular monitoring of labor, support interventions, as well as identification of complications and referral. And we will be going through some of them in more detail across the presentation. But let me spend some time on these guiding principles, which is that the care that is provided during labor and childbirth should be individualized and woman-centered. To avoid over-medicalization, any intervention that is done should have a clear medical indication, that only interventions that will serve an immediate purpose and are proven to have benefits for the woman or the baby should be promoted, and that during that care, the clear aim should be to allow that woman to have that positive childbirth experience. And that should be at the forefront of the care that they receive. The guideline has been divided in mainly these 5 big topics. So there's recommendations around care throughout labor and childbirth, mainly around respectful and supportive care. Then recommendations on interventions related to the first stage of labor, the second stage of labor, the third stage of labor, and then some recommendations on the immediate care of the newborn. So this is first hour after birth. Today, we will be mainly referring to supportive care and then the care woman and baby should receive during first, second stage of labor. And this is because this is what is reflected in the WHO labor care guide. So now I will pass over to my colleague who will introduce you to the labor care guide. Justine, over to you.
Thank you very much, Mercedes. Yeah, so why was the WHO labor care guide implemented? Well, first of all, it was to help skilled health professionals to implement those recommendations, the IPC, what we call IPC, Intrapartum Care recommendation, and to help them to implement these recommendations in practice, because we know from theory to practice it can be sometimes hard to make changes, and to help the facilitation of the implementation of essential, good quality and evidence-based recommendation. Next, please, Mercedes. And especially expanding the focus of labor monitoring, that is no longer just monitoring labor, but also taking into consideration non-clinical practices towards promoting a positive childbirth experience for every woman and every baby and family. Next, please. So what are the aims of the labor care guide? Dr. Tushara Fernando talked to you previously about the fact that the LCG, labor care guide, aims to guide the monitoring and documentation of the well-being of women and babies. And this is obvious. It's one of the objectives of this new LCG or new partograph, but it's not the only one. It's very important as well to use it so you can guide, we can guide health professionals to offer supportive care to women throughout labor to ensure the positive childbirth experience. It also aims to be a decision-making tool and helps you to make sound and evidence-based clinical decisions and assist health personnel to promptly identify and address emerging labor complications by providing reference thresholds for labor observations. And we're going to see this in a minute. And so you can take specific actions if an abnormal observation is identified during labor management. one of the objectives as well, and my colleague told you about this before, is to prevent unnecessary use of interventions in labor, and finally support audit and quality improvement of labor management. Next, Mercedes, please. So for whom is intended the LCG? Well, it was designed for the care of all women and their babies during labor and birth, for all pregnant women, regardless of their risk status. But what we recommend is to use it most like the current LCG for normal birth and childbirth, because some adaptations may be necessary for high-risk pregnancies, but it's intended to cover them like all women and babies. Where can you use the labor care guide? In all levels of care in health facilities, although the plan of action will vary depending on the level of care. Next, please. And when? Well, we recommend to use the labor care guide when the woman enters the active phase of the first stage of labor. And you're going to see in the next recommendation, in the next slides, that now we consider active phase to start from 5 centimeters, regardless of parity and membrane stages. Next, please. So let's see how the new LCG, the new partograph looks. It has 7 sections, and we will see some of the sections were adapted from the previous WHO partograph, and 2 sections are new, section 2 and section 7 in blue on the slide. The first section is to identify key information about the woman and labor characteristics at admission. We will go through each section with my colleague and give you proper recommendation linked to every section. So let me first give you the overview of the labor care guide now. Section 2 is about supportive care. It's what we were saying earlier, to promote non-clinical practices, to promote a positive experience of childbirth and labor. Section 3 and 4 are meant to identify the care of the woman and the care of the baby. Section 7 is about the labor progress. Section 6 is about medication, and section 7 is a new section about shared decision making, making a plan together along with the women. Next, please. So in this photograph, you have a horizontal time axis. So the horizontal time axis, it's to document the observation according to time. So one little box is 1 hour. And then you have also the vertical reference value axis for determination of any deviation from normal observations. And you have a special column that is the alert line, which gives you the parameters that are that should alert you and should make you adapt the plan with the women. And then, and this is new, you have a second stage section to continue the observations from the first stage of labor. Next, please. So when using the LCG and from monitoring to action, we recommend 4 steps. The first step is to assess the well-being of the mother or mother-to-be and her baby and the progress of labor. So we have specific recommendation for example, let's take the first line of section 2. You can't see, it's very small, but it's written companion. So we are going to assess if the woman has a companion of birth or not. Then the second step, once you have assessed it, is to record. So you record on the LCG, on the vertical line, hour per hour. And then we will see that there is a user's guide manual with all the abbreviation. You also have the abbreviations at the end of, at the bottom of the LCG, and it helps you to fill in the LCG correctly. In this example, the woman had no companion of birth, so you put no. And then the third step, once you have recorded, is to check And this is where you go to the alert column and you check the reference threshold. For here, companion, you can see that the alert is when there is no companion of birth, and this is based on evidence. So you have recording on step 2, you checked on step 3, and you see that this is an alert, so you have to circle it in red. So it helps visually also to spot at the parameters that need action. And so this is the last step. Step 4 is to plan. So you have to decide based on your observation whether you need to intervene or not. In consultation with the women, this is also very new, is to help women make their own decisions based on the assessment you had. And you document it in the section 7, which is the shared decision-making section. Next, please. So let's take another example. This is about one of the other sections, about the contractions. So first, you assess the woman. You have to count the number of uterine contractions over a 10-minute period. This is the assess part, step 1. Second, you take the LCG and you record the absolute number of contractions over the period of 10 minutes. Let's say it's 4. You record the 4 on the box. And then you have to check the threshold on the alert column. So the alert column tells you it's either under 2 or equal to 2 contractions per 10 minutes or over 5 contractions per 10 minutes. So 4, as I was saying as an example, is not an alert value, so you can plan accordingly with the woman. And the plan can be progress monitoring or keep up the monitoring or something. But if you have an alert value, for example, let's say you have 6 contractions out of 10 minutes, then you have to circle the parameter on your LCG and plan accordingly. So you can either verify the number of contractions, alert a senior care provider, etc. And this has to be done according to national guidelines also. Next, please. So I'm sure you were familiar with the old partograph of either WHO or another partograph. So we wanted to present the similarities between the new LCG and the old WHO modified partograph. You can click, Mercedes, please. So first, it's section 1. Section 1 is exactly, well, it's still there. It's not exactly the same. You have some differences, but the basic information are still here. Next. Then you can see in gray section for the care of the women and care of the baby. So section 3 and 4 were also on the WHO modified partograph. It was not plotted the same way. It was in a chart, whereas now you have to write the actual value and you don't have to chart it, but it's there. Next. Section 5 about the progress of labor was also here, but we will see later on. It's a major change now. There is no longer alert and action lines. Next. Section 6 about the medication is still present. Next. So those are the similarities. But for the differences, one of the key recommendations in this IPC recommendation is about the progress of labor, and it's about the definition of the latent and active phase. So the new definition we will see later, but of the active phase starts at 5 centimeters of cervical dilatation, whereas in the old partograph it was starting at 4 centimeters. And same, it's from the same study. In this new LCG, evidence-based time limits at each centimeter of cervical dilatation, whereas before we were considering 1 centimeter per hour alert line and action line. So we'll see that later on in the presentation. And then on the new LCG for contraction, uterine contraction, you just record the duration and the frequency, but you no longer record the strength. Next, please. As my colleague was telling you, in those recommendations were prioritized the voices of women to promote a positive experience of birth. So the voices of women, what do women want? We care providers are here to care for women. And so that's why these two sections were added. The first one about supportive care, and you have to explicitly record supportive care throughout labor, and the record. I'm not going in the order of the lines, but then the section 7 is also about the recording of corresponding management plan along with the decision made with the woman. Then you also have a monitoring of the second stage of labor. This is new, to continue the observation made from the first stage of labor. And you have to record actual values of what's happening, of the parameters, and highlight any deviation to those values. You can see there, my colleague is showing you all the red circles. Those are to show a deviation to the normal values based on what is written in the alert column. So next, please. My colleague is now going to introduce you to a little activity, please.
Thanks, Justine. So we will try short survey online. It has 3 questions related to monitoring of labor in your setting. So depending who you are, of course, you will respond to those questions from your view. So you have to go to menti.com. Sorry, it's not org, it's menti.com. Let me, and you should be able to see on your screen, so you can do it on your computer or your phone, and something that like the image here at the top right. It will ask for a code to be entered. The code is 51009-707. And you should be able to see an image as the one below on the slide. I give you some time to connect before launching the survey. I will have to stop sharing the presentation, and I will share live the results of the responses you will be given. So you go to menti.com, apologies for that, COM at the end, and you use the code 51009-707. I stop sharing now because I need to share the survey. And what I would do also is to put this information in the chat so you can have it. Okay. Shall we get started? So, I need to share the this way. Is this working? Yes, okay. Are you able to see the questions? Yes? Okay. Great. So I will, I see people are still voting. So the first question is, in your opinion, is suboptimal monitoring of women and babies during labor a problem or a cause of concern in the maternity wards where you work, in your setting in Myanmar? And you can see how the responses start to come in. And we can already see that, yeah, in general, I think people think that it's moderate to a serious problem. This is not surprising. I can tell you that most of the times when we ask this question, we get similar answers. We know that monitoring of women and babies during labor is not optimal in a lot of places. We will go to the other questions, try to find out from your views why. But one of the reasons why we are here now is for us to share WHO documents and try to see how we can support you. So probably next time we ask the same questions, we get different answers, and hopefully something that is more on the left side of the images. But yeah, I think that we can move to the next question. Yeah, and people have already started to respond. So in your opinion, what are the main priorities for then improving the situation we just saw in the previous question? How we improve labor monitoring in the places where you work, where you go to give birth, right? Some people think, yeah, we need more guidelines, we probably need more protocols, we need training and practice of health workers. We also need to reduce overcrowding of labor wards. People continue to respond, but most of the responses are below here. I think, oh, it's going up on training. Okay. Let me just give people some additional time. Okay, went up quite a bit on training, but then it's okay, we need to optimize staffing levels in labor ward, right? We probably need more staff, and so that person-centered care can be provided. Infrastructure, access to equipment and supplies, audit and feedback, and have some mechanisms also to provide feedback, right, to health personnel and the facilities. So yeah, I think that this gives an idea of there's a range of things that need to happen, right, at all levels, from training providers, having guidelines, but also at the health system levels, optimizing staffing levels, having better infrastructure. So none of them are easy, and probably all of them should happen at some point. So I hope that this will also help you to see. It might be a good exercise just to go back and prioritize, okay, what of those things I can do next in my hospital. The last question is on strategies that you think could facilitate the introduction of the WHO Labor Care Guide, the tool that Justine just introduced to you. And we just give options on different strategies. Let me try to see. It seems like building consensus, having consensus processes for adaptation of LCG is something people think will be important, as well as, again, adapting, updating guidelines. So I guess this tool could be introduced. But then seems like those with the higher rates are having training, face-to-face training for health workers, and having materials to be able to train them on the tool, as well as having the possibility to monitor how labor care guides use, and also how it affects some key perinatal outcomes. I see still people are responding, but I think that, yeah, those are your views. And I must say that this is also very helpful for us, because it also helps us to see where next to go, or where are the needs of people who work in maternity wards in different places. Great. Okay, I stop sharing this, and I will go back to our presentation. Where is it? Okay, it's here. And what we will do now is we will take you through. Sorry. Okay, you should be able to see the whole screen now. We will take you through the different sections Justine briefly describe. And again, we will share the presentation up to the end. So the first two sections, 1 and 2 in the LCG, identifying information and supportive care, are those that you can see here below. And from now on, you will have these larger images, so you can better see what is in the tool. So you can see this first section helps to identify the woman and collect some key information that will help you take decisions during labor and childbirth. It doesn't include everything. Of course, these have to be complemented with using medical records if there's need to add more information to it. The second section is supportive care, so includes whether the woman has a companion of choice, whether she has and receives pain relief during labor and childbirth, oral fluids and posture, meaning whether she has been able to mobilize, to walk, for example, through our labor, but also whether she was able to adopt position of birth of her choice. And this is related to several recommendations in our guideline. And the first one is the use of definitions of active first stage of labor. Justine already mentioned it, that this new definition of active first stage, regular painful uterine contractions with some degree of cervical effacement is not new, but what is new is that cervical dilatation is considered from 5 centimeters until full dilatation, that this will be 10 centimeters for every woman. So this could be primiparous or multiparous woman. And it's at from 5 centimeters that we recommend the LCG to be used. So during this active first stage of labor. The second section includes other recommendations, mainly about supportive care and supporting the right of the woman to have respectful care, a companion of choice, and receive other supportive care, oral fluids, food, and pain relief during labor and childbirth, as well as being able to mobilize during labor. Other recommendations related to these are specific to providing relaxation techniques, manual techniques, also to relieve pain. As you can see, these include a bunch of different interventions, muscle relaxation, breathing. For example, on the relaxation techniques, in the manual techniques, this is mainly around massage or application of warm packs that are recommended for women if they request pain relief. Section 3 and Section 4 are those where you will record more clinical findings around the fetal well-being and the maternal well-being. As you can see on the slide, these include fetal heart rate, the status of the amniotic fluid, fetal position, caput, molding for the baby, and vital signs for the woman, pulse, blood pressure, temperature, but also findings from urines, whether it's proteins, for example, or acetons. This is related to recommendations we have in the guideline about how to monitor fetal heart rate. Their recommendation is to use intermittent auscultation, either with Doppler or Pinar stethoscope, and this is on admission and also during labor. We don't recommend routine use of continuous cardiotocography, so monitoring fetal heart rate continuously, and use this technology either at admission or during labor if women don't present any complications and are undergoing a spontaneous labor. Justine, I think that is over to you.
Thank you very much. Yeah, so section 5 is about the labor progress. And you can see here on the screen this section, not the entire section, because there is also the monitoring of contraction we discussed before. But this is one of the main changes as well on section 5. And we are going to go through it. You can see on the left the cervix and the descent, 5, 6, 7, 8, 9, 10 centimeters, and you can see values on the alert line. So let's discuss that now. Next, please. What we have to bear in mind is that, next, please. What we have to, thank you, have in mind is that every birth is unique. You can't ask every woman to go at the same pace for cervical dilatation. So some labors are going to progress quickly, some others don't. And the risk is if we intervene too soon, then unnecessary medical intervention can be used, and this should be avoided if, of course, the woman and her baby are in good condition. So if the labor is progressing, if the woman is well, if the baby is well, if you have assessed section 3 about the care of the baby, section 4 about the care of the woman, everything is well, then it doesn't matter if the woman cervix is not dilating at 1 centimeter per hour, what we had in mind before. And labor may not actually accelerate until the cervical dilatation threshold of 5 centimeters is reached. So all the latent phase can take time. And therefore, the use of medical intervention to accelerate labor and birth, such as, for example, oxytocin augmentation or C-section, before this threshold is not recommended. Of course, providing fetal and maternal conditions are reassuring. Next, please. So we mentioned it several times during the presentation, but it's one of the key changes in these recommendations that are going to require time for health professionals to implement and be used to. But labor progression, from what we have and the new evidence we have, at 1 centimeter per hour can be very unrealistic for many women. And so this threshold shouldn't be used as a trigger for medical interventions. And this is why we have developed new alert signs that we saw before. So if the woman's cervix is dilating at less than 1 centimeter per hour, it does not mean that you have to intervene. It can be unrealistically fast for some women, and if it and the woman goes slower than 1 centimeter per hour, if she is well and the baby is well, it should not be a routine indication for obstetric intervention. There is insufficient evidence to support the use of the Partograph alert line as a classifier to detect women at risk of adverse birth outcomes, and this is why also the new labor care guide was implemented to change those alert lines. Next, please. It's also very important to inform women. So in the quality of care, there is communication, effective communication with the women. And so it's important to inform women and to inform them about the duration of the active first stage of labor. Usually, it does not go beyond 12 hours in first labors and 10 hours in subsequent labors. This doesn't mean that from 5 centimeters to the birth, it's going to be always 12 or 10 hours. It can be less, but it shouldn't go beyond. And you have to inform the women if you're a health care professional. And then after having the consent of the women, we recommend digital vaginal examination at intervals of 4 hours. Every 4 hours, of course, given that everything is fine, again, normal labor, normal birth, well-being of mothers and well-being of babies, for routine assessment of active first stage of labor in low-risk women. Next, please, because this sentence is going to be after. Thank you. And then in the information given to women, it's important to inform them as well that in first labors, birth is usually completed within 3 hours after the second stage of labor is reached. And in subsequent labors, birth is usually completed within 2 hours. So we have many questions from countries about this. It does not mean that the second stage of labor for women, primiparous women, is and has to be 3 hours. It means that it can be up to 3 hours and up to 2 hours for subsequent births and labors. What is recommended in this recommendation is also the use of techniques to reduce perineal trauma, because you will see that episiotomy, routine episiotomy is not recommended, and to reduce perineal trauma and facilitate spontaneous birth. In the recommendation are recommended interventions such as the perineal massage, warm compresses that you can put on the perineum during the childbirth, and also hands-on technique. And then what is recommended as well is to make women listen to their body and listen to them when they have the urge to push, and not be focused on what health professionals want, but really communicate with the woman. And this is why we talk about decision-making and shared decision-making, and encourage and support women to follow their own urge to push for delivery. Next, please. Then section 6 is about medication. So we're going to see the recommendation linked to this, but mostly oxytocin, medicines, other medicines, and IV fluids. And the section 7, we already mentioned it, is new, and it's about shared decision-making. So you have one part about assessment, Assessment is the general assessment, like your conclusion of all the observation you made. For example, for this woman, it's the same case. You can find it on the user's manual. Pain relief required. And then once you have made your assessment, you can plan with the woman. And here it was to offer a companionship and relaxation techniques of continuation of routine monitoring. So you can see here the plan is not about usual medical interventions. It's about non-clinical medical interventions, but that have been proven by evidence to have a real impact on making childbirth positive for women and families. Next, please. So what are the recommendations linked to these sections? First, respectful maternity care. It enables informed choice and continuous support of the woman, and effective communication, we mentioned several times during the presentation, between maternity care providers and women in labor using simple and culturally acceptable methods. And these include, giving information we just saw before about the duration of active first stage of labor and second stage of labor, and also adapting the pain relief according to women's preferences. So here we put pharmacological because it's linked to section 6, but it can be also non-pharmacological, as my colleague mentioned for section 2. Next, please. So in these recommendations, you have practices that we at WHO don't recommend. This is the routine and liberal use of episiotomy. It's also the manual fundal pressure application to facilitate childbirth, the routine antibiotic prophylaxis for uncomplicated vaginal birth or with episiotomy. Next, please. It's also the administration of enema, routine perineal and public shaving prior to giving vaginal birth, and the use of oxytocin, antispasmodic agents, and intravenous fluids for preventing labor delay. So those were practices that are still, I'm saying were practices, but are practices that are still current in many health facilities around the world, and that are not recommended in current practice for normal birth and normal labor. Next, please. So now we are done with presenting the key recommendations linked to the LCG section. Of course, this webinar is kind of short. We are developing a WHO trainings on LCG that require more time. So we expect that, and we hope that this short presentation gave you, the wish to go further with the information. And you can actually go to WHO website and find these key resources. The first one is the LCG Users Manual. This is very important. It's a guide that you can use with all relevant information. There is also a clinical case that is going to guide you step by step, section by section. And we strongly recommend you to use this user's manual. Then you can find on WHO website the Intrapartum Care for Positive Childbirth Experience recommendations. And also 2 slide docs, so 2 PowerPoint presentation, one on the LCG dissemination and the other one on WHO IPC recommendation. And at WHO, we are working on an implementation package as well to implement the LCG in countries and the Intrapartum Care guidelines. Next, please. There is also online course that has been developed. Actually, it was after a webinar done in the African region and organized by WHO, Regional Office for Africa, United Nations Population Fund, and United Nations Children's Fund. It's an introduction to the LCG, and it's a self-paced course. So you can go on WCEA, either website, either application, and you can find Introduction to WHO Labor Care Guide. You have some questions, and you can actually learn more from what we just presented this morning. Afternoon for you, sorry. Next, please. If you want to go deeper, so once you have read all WHO documents, once you have done the course and you still are eager to learn more, you can find those 4 articles that have been developed by researchers and WHO team about the development of WHO LCG in the 23 countries, about the usability, acceptability, and feasibility of this LCG. With a multi-country evaluation, but also exploration of midwives' views on the latest WHO LCG. And last but not least, a commentary that provides the evidence base for changes made to graphical display of labor progression, as we were mentioning several times in this presentation. So you can find these articles online. They are free access, and it's food for thoughts. Next, please. In summary, the LCG is a new tool developed by the World Health Organization that is going to facilitate the implementation of WHO intrapartum care recommendation and model of care. It's not only a monitoring tool, but it's also helping health professionals to make a sound, efficient, and evidence-based recommendation taking into account non-clinical intervention to promote a positive experience of childbirth for every woman and every babies and families. It encourages best practices and aims to promote good quality and respectful care for all women and newborns and their families. And WHO developed educational and dissemination materials to support policymakers, health administrators, and health personnel to successfully introduce and use the WHO Labor Care Guide. And this is why the Mentimeter was also very important, what the activity you did with my colleague, because we could see from your answers that training health professionals is not enough, and if you want to implement the LCG and the recommendation successfully, some deeper changes are needed. Next, please. So thank you so much for your attention. We are here to answer to all your questions.